Good afternoon and welcome back to Cardiovascular Grand Rounds. An important announcement for next week is that we will have Grand Rounds at Macy, and as opposed to here just for next week, because this room is being utilized for, I think, an inspection from DNB. Next week, Dr. Hadri, our newly recruited interventional cardiologist, we'll talk about a topic that actually is very important for us because he was able to expand the offerings in our cath lab, which is the topic of complex PCI, particularly left main and CTOs. And then the week after, I have announced him before, will be Dr. Kayam, who will talk about an update on pericardial cardiomyopathy. And actually, we'll have two visiting professors back to back because the visiting professor for May that I will announce her next week will be the first week of May. We all know that cardiac MRI has been penetrating more and more the field of cardiology and of course other specialties. And it has gotten to the point that we don't feel that a cardiac evaluation is complete without a cardiac MR studies, particularly in certain conditions. We used to think of cardiac MR as a picture that was more prettier than echo picture, not operator dependent, would give us better information about LV function. We have advanced the field much more since then, but still there are some questions, at least to us ignorant cardiologists, about CMR. So I'm very pleased that Dr. Ranjan, who is one of our advanced imaging experts, together with Dr. Fuse, will talk about parametric mapping. I don't even pronounce it right, let alone be able to explain it. So I'm really looking forward to this lecture. Pragya?
Thank you, Dr. Panza. Okay, I'm going to apologize before I begin because a lot of this is focused on LGE, and there is because the evidence for LGE and the assessment of sudden cardiac death and sudden cardiac arrest is a lot more robust. So there's one slide and a little bit of information about parametric mapping, but most of this is really going to be very LGE focused. So what I hope to cover in today's Grand Rounds is defining the problem of sudden cardiac arrest and sudden cardiac death, the evidence behind the current recommendations for primary prevention in non-ischemic cardiomyopathy, the evidence behind that and the challenges in using only LVEF, looking at specific populations like dilated non-ischemic cardiomyopathy, HCM, cardiac sarcoidosis, ring-like pattern of LGE, so arrhythmogenic LV cardiomyopathy, some of the challenges in assessing LGE, what the practice patterns are around the country, what the role is for parametric mapping, and what can we expect in the future. So beginning by sort of defining the problem of sudden cardiac death, we still see about 390,000 sudden cardiac deaths that occur out of hospital, 200,000 in the hospital, and it accounts for 50% of all cardiac deaths. 50% of all sudden cardiac deaths are the first cardiac event ever. And so if we look at this at a population level, more than equal to 50% of patients that have sudden cardiac death, it occurs in the general population. It's the first ever recognized clinical event. And if you, the annualized risk in a population with patients above 35 years of age is 1 in 1,000. So we've done really well when it comes to overall risk reduction in cardiovascular disease, but we haven't seen a proportional reduction in sudden cardiac death, even though the incidence of ischemic heart disease related sudden cardiac death is decreasing. And the greatest challenge seems to be in identification of this high-risk subgroup that has no known risk factors, but their first event tends to be sudden cardiac arrest. We also know that within the ischemic heart disease group of patients that have an EF greater than 35% account for most coronary heart disease related sudden cardiac death. So even the tool that we currently use, which is EF, is imprecise within that subgroup. Of the patients that do have ICDs, only about 20 to 30% of those patients receive appropriate therapy. So I think the goal is that to better identify patients that are a more precise, smaller subgroup that have a higher probability of receiving appropriate ICD therapies and that are currently being missed by our guidelines, and also by recognizing patients that would probably not benefit from ICD therapy. So guidelines continue to state that in non-ischemic cardiomyopathy, patients with NYHA class 2 to 3 symptoms with an EF of 35% or less, as long as they've been on GDMT for 3 months and have survival expectation greater than a year, would benefit from an ICD. Or if they have a lamin mutation with 2 or more risk factors, male gender, non-sustained VT, a mildly reduced EF, and a non-missense mutation, we should be considering ICD placement in those as well. This is what our current guidelines state. And the evidence comes from 2 trials. Actually, it comes from 4 trials, but I'm going to mention the 2 most important ones, DEFINITE and SCUD-HEFT. And so DEFINITE randomized patients with non-ischemic cardiomyopathy that were on GDMT, so ACE inhibitor beta blockers, to either ICD or no ICD. And they showed a significant reduction from arrhythmia and non-significant reduction in death from any cause. SCUD-HEFT then went ahead to randomize patients, which was a combination of ischemic and non-ischemics, to placebo and routine heart failure treatment, amiodarone and routine heart failure treatment, and ICD, and again, standard of care heart failure treatment. And again, they demonstrated a 23% risk reduction in overall mortality. Why we began to question that evidence, of course, is because of the Danish trial and the 11-year outcome. So the Danish trial looked at 556 patients, non-ischemics only, that were symptomatic, had systolic heart failure, and they followed them up for a total of about a little over 5 years, randomizing them to either ICD or standard of care. And in those patients, prophylactic ICDs were not associated with a significantly lower long-term rate of death from any cause as compared to clinical care. And if you look at the 11-year outcomes of SCUD-HEFT as well, it was shown that at the 11-year mark, so anywhere beyond the 5 or 6 year mark, the patients that truly benefited from this therapy were the ischemics and not so much the non-ischemics. So based on all of this, primary prevention ICD placement in non-ischemics has been has been questioned, or the evidence behind it has been questioned. And so the questions we ask are, non-ischemic cardiomyopathy consists of a very heterogeneous, different set of patients, very different risk profiles. And so EF may not be good enough to risk stratify them. So how can we do that a little bit better? And how do we better identify high-risk patients independent of EF? And can we use MRI characteristics to help us understand that risk a little bit better? So what MRI does well, we've known this for a long time, is more accurate assessment of LV volumes and EF, more accurate assessment of the RV that becomes particularly important in diseases like sarcoid and ARVC. And then, of course, late gadolinium enhancement, which is going to be the focus of this talk, but also a couple of other parameters like parametric mapping, which consists of T1 mapping, ECV, and global longitudinal strain. So what is LGE? Because this is a question that comes up often in conference. And it's very simple. It's a principle of contrast imaging based on wash-in, wash-out kinetics. So a bolus of gadolinium contrast tends to go from the intravascular space to the extracellular space. And if there's any reason that the extracellular space is increased, so patient that's had an MI, so there's been necrosis of myocytes, or another disease process, let's say amyloid, that results in expansion of that extracellular space, will result in accumulation of gadolinium. We know by pathology that there are 3 different types of myocardial fibrosis: infarct fibrosis, which is that classic subendocardial to transmural fibrosis following the ischemia necrosis wavefront; replacement fibrosis, which you typically see in post-myocarditis patients and is more linear, has a non-ischemic pattern; and interstitial fibrosis, which is really difficult to quantify based on LGE because by definition it's diffuse, and so you don't really recognize it as a focal area of enhancement. You can really only recognize it using parametric mapping like T1. So far, we've known that EF is the best known predictor of arrhythmia risk, but what it really was supposed to be was an indirect measure of scar size, because we also know that myocardial scar and the presence of viable myocytes within myocardial scar form the substrate for reentrant arrhythmias. So naturally, the question was, well, if we have a way to look at scar a little bit better, shouldn't that be the way that we gauge risk? And so there were a number of studies that were done in the early 2000s. They were all predominantly small studies. This is a meta-analysis of about 29 of those in patients that had dilated cardiomyopathy, EFs anywhere between 20 to 43%. And again, all of these studies showed that LGE was significantly associated with the arrhythmic endpoint in the overall population. But these are small observational studies, and there was heterogeneity in the study populations. But this then led to a couple of additional questions. One, can we identify patients that would benefit from a primary prevention ICD independent of their EF? 2, in patients that don't have SCAR and don't have significant LGE, do they really require ICDs even if they have severely reduced LV function? And can we use any cutoffs or any algorithms that we know of, and how should we design these? So I think when in MRI, the 3 things that we focused on were LGE or total scar burden, a pattern of LGE that was more concerning, and parametric mapping, again, T1 mapping and ECV. So with regard to SCAR, I think the 3 most important studies that have come out in the last couple of years are the ICM SCAR study, the LGE DCM study, and the Derivate registry. So I'll start with the LGE DCM study because this was about over 1,000 patients across 2 centers in the UK and Spain. They looked at dilated cardiomyopathy patients, so anyone with LV systolic dysfunction, increased LV and diastolic volume, and they excluded the usual. They excluded all the ischemics, they excluded infiltrative disease, ARVC, sarcoid, amyloid, congenital heart disease, and valvular heart disease. And the way that they assessed LGE was visual assessment. So they used the 17-segment model, and then they quantified it based on the 17-segment myocardial model as to whether it was 25% of that segment, 50%, et cetera. And they followed these patients for a total of 3 years, looking at 2 endpoints. Their primary endpoint was a composite arrhythmic endpoint, so appropriate ICD therapies, monomorphic or polymorphic VT, resuscitated cardiac arrest, and sudden death. And secondary endpoints included cardiac death and a combined heart failure endpoint, et cetera. And they identified that if you look at just that primary arrhythmia endpoint, then both gadolinium enhancement and EF are independent predictors. And then they also recognized that there were certain patterns of LGE that are high risk. So epicardial, transmural, combined septal, and free wall LGE. A lot of this we already knew based on the prior studies, but they used this information to then make an algorithm to classify patients into low, intermediate, and high risk. And what they found was that if you look at the low risk patients, ones that had an annual event rate of less than 0.2%, these were patients that had a reduced EF, but it was greater than 20%, and no LGE. And they had hypothesized that these patients would likely not benefit from ICDs if they had an annual event rate that was so low. The high-risk patients, which we probably already identify, are the patients with EF less than 35%, but in this case also had LGE. And the ones that were likely missing are this intermediate high-risk group, which also has an event rate of about 2.8% per year. They have LGE, they have a high-risk LGE distribution, and their EF is greater than 35%. So our guidelines would likely miss these patients, and we should probably look at these a little bit more closely. They also determined that in patients with an EF of greater than 35%, the only independent predictor of arrhythmic events was LGE. And again, in patients, EF greater than 35%, but had LGE, their risk of arrhythmia was greater than patients that had no LGE, but a reduced EF, so people that were likely missing. And they also identified this true low risk group, which probably will not benefit from primary prevention LPV, and commented on that high risk LGE pattern. So the NICM SCAR study, which I think all 3 of these were done in 2021, was done here in the US. And they took a slightly, a little bit of a different approach, and they focused more on SCAR burden. So this was 1,000 patients, non-ischemic cardiomyopathy, 3 centers in the US. Similar inclusive criteria, EF less than 50%, no evidence of coronary disease, and excluded all the usual valve disease, sarcoid, infiltrative heart disease, et cetera. And they followed them for about 5 years, looking at a couple of different endpoints. So all-cause death, sudden cardiac death, an arrhythmic composite endpoint, and a heart failure composite endpoint. And they focused a lot on quantification of LGE, so total scar burden, which is what we often quote. This was done by a visual assessment, again, 17-segment model, and a semi-automated quantification, which was reported as a percentage of LV mass. And what they found is if you look at the SCAR versus no SCAR group and the reduced EF versus preserved EF group, when you're looking at all-cause death or cardiac death, they're both associated with increased risk. When you look just at sudden cardiac death, there is no significant association with the reduced EF group. You only see it in the LGE group. And again, if you look at arrhythmic composite endpoints, it's only the patients that had SCAR, that had significant SCAR, independent of the EF, that had an increased risk of arrhythmias. With the heart failure composite event group, the heart failure composite event endpoint, you saw a difference between both. So again, when it comes to arrhythmia, it was only the patients that had scar that had significant events. And this was true depending on how much scar there was. So if you went from all patients, no scar, up to 10% scar, you saw that the 5-year event rates of arrhythmia continued to increase, but then they plateaued over a period of time when they plateaued at a percentage of scar. So at around 20 to 25% scar, the arrhythmia event risk is probably the same, but it goes up from 0 scar to 20 to 25%. And this was independent of patients' EF. The third study, which was the Derivate registry in Europe, looked at 1,000 patients, all of them non-ischemics, EF less than 50%, follow-up of 959 days, primary endpoint, all-cause mortality, secondary endpoint, again, an arrhythmic endpoint of major adverse arrhythmic events. And they then identified patients that identified predictors of all-cause mortality. So predictors of all-cause mortality were age, more than 3 segments with mid-wall LGE. Independent predictors of arrhythmic events were male gender, also something that we knew, dilated LV, more than 120.5 index volume, and again, the presence of 3 segments with mid-wall fibrosis, which is considered a high-risk pattern. And so they followed these patients and they divided them based on they created another risk score based on these 3 factors. And they followed these patients and determined what their risk of arrhythmic events was. And clearly, again, you see separation of the curves, not if you use EF, but if you use that composite risk score. So patients that had those 3 features were at the highest risk of having major arrhythmic events over a period of time. Do not see the same with EF. When they then looked at it further, they divided their population into the reduced EF group and that preserved EF group. So if you look at the preserved EF group here, that little 5% red of the pie chart, red segment of the pie chart, are patients that have a normal EF, but they have some degree of scar, and they have that composite risk score greater than 5. So again, their annual event rate is somewhere around 7.7%, and we're missing all of these. If you look at patients with an EF of less than equal to 35%, you still have about 29% of that population has an event rate of less than 1.1% per year. So maybe we should question putting ICDs in those patients. But I think key points based on these 3 studies was that, EF probably plays a significant role in predicting all-cause mortality, sudden cardiac death, all-cause mortality, cardiac death, and heart failure outcomes. But when it comes to specifically predicting arrhythmias and sudden cardiac death, it's really LGE that tends to do a better job. That risk increases with risk in LGE burden, so quantifying that scar is important, but then it probably plateaus at a certain point. And there's certain specific patterns of LGE that are more concerning, like mid-wall fibrosis. And it's probably important in the future for us to create some kind of a risk score to identify patients at both ends of the spectrum. So the very low risk groups that have an annual event rate of 0.2% or less, as we saw in that first study, that probably won't benefit from an ICD. And the very high risk group that, even though they have a normal EF, have a high enough scar burden that they have a high annual event rate. And we should probably consider parameters like age, gender, LV volume, EF, but really that combination of burden and LG burden and pattern. Now, there are 3 specific populations that I would like to talk about where we do incorporate LGE and use that to risk stratify them a little bit better. And I'll start with HCM. Now, HCM has probably been one of the best success stories in terms of prevention of sudden cardiac death. So if we look at the era pre-2010 and you look at the era post-2010, globally around the world, there's been a marked reduction in incidence of sudden cardiac death. So in North America alone, it's gone from 0.55% to 0.15%. And this is likely because of a number of reasons, right? We've gotten better at creating awareness among patients, screening family members. There's been new medications. We've gotten better at treating them with intervention and septal myectomies, et cetera. But we've also gotten really better at risk stratifying those patients appropriately and placing primary prevention ICDs. And I mention this because it's one of the few subgroups that the guidelines actually do talk about focusing on extent of LGE and diffuse extensive LGE representing fibrosis more than equal to 15% of LV mass, either through a quantification method or through visual assessment. The guidelines say that in patients where you can't really make a decision about ICD, that should be taken into consideration. So where does the data for that come from? So we knew based on a number of studies, this is a meta-analysis of about 5 of those, that any amount of LGE increases their risk of sudden cardiac death. So this was 2,900 patients followed for about 3 years. If there was LGE at all, there was a 3.4-fold increase in risk for sudden cardiac death, a 1.8-fold increase in all-cause mortality, and a 2.9-fold increase in cardiovascular mortality with a trend towards increase in heart failure death. We knew this from prior studies. And then this was a study that was done by Dr. Marin and his colleagues, where single study, 4 centers, over 1,000 patients that were referred for MRI and then followed for a period of over 3 years. And they found that with increase in extent of LGE, there is a significant increase in events in sudden cardiac death. And so if it was greater than 15% of the LV mass, that meant a 2-fold increase in sudden cardiac death. And based on this, it was incorporated in the guidelines. The challenge with HCM and quantification of LGE in HCM specifically is that there tends to be significant variability in quantification based on methods. And so there was a lot of discussion and debate around, how accurate are we when we report that scar burden in these patients? And this is more of a problem in HCM patients because they tend to have very patchy LGE, they have interstitial fibrosis. And so if we started looking at every HCM patient with some amount of LGE and recommending a primary prevention ICD, everyone would get it, right? So that wouldn't be cost effective and it wouldn't make sense. The second challenge is there isn't a standardized method of quantification. So you can either do a qualitative assessment of SCAR where you divide the myocardium into the AHA 17 segment model, determine whether the amount of myocardium involved is less than 25% of the thickness, 25 to 50, 50 to 75, or 75 to 100% of the thickness, use a 5-point scale and then present it in this way and say, this is the total percentage of LGE. Again, visual assessment, qualitative assessment only. Or you can use a whole host of other methods. There are about 4 or 5 of these. The one that correlates best with histopathology is the STRM method, and I'll explain that. Basically, all we're doing is we're looking at normal myocardium, which is dark, signal intensity of normal myocardium, comparing that with a grayscale threshold, which is 4 to 5 standard deviations above that, and saying that's going to be SCAR. So I see that, that's SCAR, that's what's going to get quantified. And that correlates best with histopathology. The other method that correlates well is full width at half maximum, which again sort of uses a signal intensity that is midway between normal and SCAR. And these tend to correlate best with histopathology, they're reproducible, and they correlate well with manual assessment. Having said that, I think we were debating about this a few days ago on the imaging WhatsApp group, and everyone tends to say that in clinical practice, it's not realistic to use a single method, and everyone does some degree of manual adjustment or visual assessment. So even when I'm quantifying SCAR, if the computer calls it SCAR and I don't believe it's SCAR, I will eliminate it. If the computer does do this, it takes the LV cavity into account, and you have to eliminate that, otherwise you're going to overestimate. We saw that happen in one of our HCM patients. And so in general, the consensus is that there has to be some degree of manual adjustment. You have to incorporate visual assessment in clinical practice. So we should probably rely less on these very specific cutoffs of 6% and 10% and 15%. And there's probably going to be a lot more reader agreement if we're talking about minimal, moderate, or extensive LGE. And specifically in the HCM group, where we see a lot more interstitial fibrosis, in the future, we should probably incorporate T1 mapping, because T1 mapping will account for that, for fibrosis that we're not able to catch on LGE. The second population that I wanted to talk about was cardiac sarcoid patients. Again, this subgroup of patients, the guidelines do state, take SCAR into consideration when you're thinking of a primary prevention ICD. So it's a class 2A recommendation. Patients that have an EF of greater than 35% have had syncope or have extensive SCAR by either cardiac MRI or PET, we should consider them for a primary prevention ICD. But it's somewhat vague because they don't really define the extensive LGE, right? And again, there's probably going to be some variability here when we talk about extensive LGE. So this is the study that everyone quotes, and everyone that's using it in clinical practice is using this 5.7% cutoff in terms of scar quantification. And so this was a study that was done by, I think it was the Mayo Group. Chetan Shenoy and his colleagues did this at the Mayo Group, and they looked at 290 patients that had biopsy-proven either cardiac sarcoid, extracardiac sarcoid, or both cardiac and extracardiac sarcoid. And they established an LGE cutoff of 5.7%. And I'll talk about how they did that. They looked at a composite endpoint of ventricular arrhythmia or sudden cardiac death. And they divided that cohort into patients that would meet their primary endpoint based on the class 1 recommendations, the class 2A recommendations, either recommendation, et cetera. And what they found was that the highest annualized event rate were in patients that had a spontaneous sustained VT or sudden cardiac arrest. As we expect, they've already declared themselves. But if you just looked at patients with a preserved EF, so not preserved, but only mildly reduced EF, so greater than 35%, and they set that cutoff of 5.7% LGE by SCAR, they also had very high annualized event rates. They had event rates of about 12%. And so again, this number that gets quoted 5.7% all the time isn't really in the guidelines, but it's this paper that gets referenced and is used to make the argument. Having said that, it was also shown in this paper that the presence of any LGE less than 5.7% didn't really have the same result, or didn't result in the same increased risk. The same group of patients, the same group of authors then focused on another study where they looked at LGE patterns. And so this was 504 patients with histologically proven sarcoid. They established 4 phenotypes based entirely on LGE pattern. So phenotype 1, normal EF, no LGE. Phenotype 2, abnormal EF, no LGE. 3, what they called pathology frequent LGE and pathology rare LGE. And I'll talk about that. So pathology frequent LGE are some of the high risk patterns that we see on cardiac MR. So subepicardial LGE in the LV, multifocal, septal, that is free wall, RV side of septum involvement, and RV free wall involvement. So, and these are just sort of examples of those patients. So I'm just going to focus on this second subgroup here for a second. The abnormal EF, no LGE, right? In those patients, they didn't see an increase in arrhythmic events. There was an increase in heart failure and hospitalization. So again, sort of goes back to that point that your EF is reduced. It does prognosticate in terms of heart failure admissions and hospitalization, not so much arrhythmia. When you talk about pathology frequent LGE that had those classic findings on MRI, these were the patients that had VT, needed ATP, ICD shocks, but had no heart failure events. And then the pathology rare LGE, so they had some amount of LGE, but not one of these classic patterns. They had no arrhythmic events, no heart failure events. And so when we followed these groups over a period of time and they looked at that cumulative incidence of either the arrhythmic endpoint or the heart failure endpoint, again, the dangerous pattern of SCAR, they did the worst in terms of cumulative incidence of arrhythmic events over time. The other 3, whether it was EF normal, abnormal, some amount of LGE, they did the same in terms of arrhythmia. In terms of heart failure, there's a little bit of a spread again. So again, like we expect, reduced EF probably plays a role here. But even in the heart failure group, clearly the patients that had the pathology frequent LGE did the worst. And they call this pathology specific LGE because these are the cardiac damage patterns that they tend to see on autopsy and in patients that undergo heart transplant. So these cardiac damage patterns have a high risk of ventricular arrhythmia, high risk of heart failure, independent of the SCAR burden, independent of EF. And absence of that pathology frequent LGE is still a pretty low risk, even if there's some amount of LGE present and even if the EF is low. Okay, so the key take-home points for this, based on these studies, was if patients have an EF greater than 35% and increased SCAR burden, I'm not going to focus so much on that 5.7% because it was shown in one paper, but it doesn't make a lot of sense, and it's really hard to be accurate to a 0.1 decimal. But they have a high annual risk. High risk LGE patterns, and we see this all the time in cardiac sarcoid patients. They also have high risk in terms of arrhythmias and heart failure both. But if there's just a mere presence and a small amount of LGE, that probably isn't as much of a risk factor, again, unless it's extensive. And the last subgroup that I wanted to talk about, which I think we've debated back and forth now in the last 10 days, is this classic ring-like LGE pattern or scar pattern in patients with non-ischemic cardiomyopathy. So what this is it's a subepicardial or mid-myocardial late gadolinium enhancement that involves more than 3 contiguous myocardial segments. And a number of studies have looked at this and have shown that these patients have an increased risk of arrhythmias independent of EF. They've also shown that this is a common imaging finding in patients that have left dominant arrhythmogenic cardiomyopathy or LVAC, and there's probably some partial overlap with the arrhythmogenic subtypes of dilated cardiomyopathy. So the question is, what is the relationship between that pattern and arrhythmia events in dilated cardiomyopathy? So I'm going to talk about 2 studies that looked at patients that had non-ischemic cardiomyopathy and again assessed their risk of arrhythmias. So this study was about 686 patients, multiple centers in the US, Japan, and Europe. And these were patients that were diagnosed with non-ischemic cardiomyopathy, so they had a reduced EF. But again, remember, the median EF in this subgroup was 57%, so mildly reduced EF, if at all, right? They had a completely normal physical exam, EKG normal, echo normal, ischemic evaluation normal based on invasive and non-invasive methods, but they had frequent PVCs or non-sustained VT that had been diagnosed. And so they looked at time to a composite outcome of all-cause death, resuscitated cardiac arrest because of VFib or hemodynamically unstable VT, and appropriate ICD therapy. We knew nothing about the genetics of these patients. And they divided these patients into three groups. The ring-like pattern, so 28 patients, 4% of that total number of 686, they were all younger, and that composite outcome occurred in half those patients. The non-ring-like pattern, which had some LGE but wasn't this dangerous pattern, it still occurred, but in about 19% of patients. And in patients that had no scar, they saw that outcome in 0.3% patients. So again, clearly demonstrating that pattern of the involvement of 3 contiguous segments, subepicardial or mid-myocardial, is clearly dangerous, and it's clearly a substrate for arrhythmia. And this was true independent of scar burden. So they quantified scar burden, and if they had scar burden less than 5%, or if they had scar burden greater than equal to 5%, if they had that ring-like scar, their risk was significantly higher even after adjustment for EF as well as multivariable adjustment. Okay, this was the second study where they looked at 193 patients that underwent MRI between 2018 and 2020. Again, they defined non-ischemic cardiomyopathy as either EF less than equal to 50% or biventricular dysfunction and an increased LV volume. And they followed these patients for about 13 months, looking at risk of a composite outcome of arrhythmias or all-cause mortality. And they divided these patients into 4 groups: no scar, focal or mid-wall scar in the septum, multifocal LGE, and this ring-like scar. And again, if you look at the 4 groups, the no LGE group and the ring-like LGE group have normal EF or better EF than everyone else. They have smaller LVs than everyone else, so we would completely miss these patients, right? If they had a ring-like LGE or multifocal LGE, so a lot of areas were involved, they probably had similar LGE burden in terms of quantification. But if you look at the outcome in those patients, it occurred in 6% of patients that had no LGE, 10% of patients that had focal LGE, 25% of patients with multifocal LGE, and about 42% of patients with ring-like LGE. So clearly, normal EF, similar scar burden, normal-sized LVs, a lot more arrhythmia. And there was no difference in incidence of the arrhythmic events, regardless of what the EF of these patients were. And they found that there was both the ring-like pattern and the multifocal pattern of LGE were both associated with a significantly increased risk of ventricular arrhythmias. So, and I'll talk about this only briefly because the whole concept of this ring-like pattern of LGE came up when we were trying to identify which patients have familial dilated cardiomyopathy and how better can we diagnose patients that actually have preserved LVEF. So over 60 genes have been identified in familial dilated cardiomyopathy, but we still tend to underdiagnose arrhythmogenic left ventricular cardiomyopathy because there really aren't good diagnostic criteria, and the sensitivity for this based on ARVC criteria is very low. We do know that there are certain genes that are a more malignant phenotype, and this is independent of LV function. So LMNA, the FLNC genes, desmoplakin, and of these, DSP13 and FLNC14 are considered genetic causes of ALVC. So I'll talk really briefly about desmoplakin cardiomyopathy because I was fairly convinced that the patient we had last week was this, but it isn't. He wasn't. But this is an LV predominant cardiomyopathy. ARVC, very poor sensitivity for diagnosing these patients. They looked at a cohort of 107 patients that had DSP mutations and PKP2 mutations. And these patients typically present as myocarditis with myocardial injury, and they get misdiagnosed multiple times as either myocarditis or sarcoid because the clinical presentation is very similar. We know that in these patients, LV fibrosis precedes LV systolic dysfunction, and about 35% in this cohort had a normal EF, but they had LGE. And again, they have this classic subepicardial pattern of LGE. So they did a study where they tried to see if they could match the genotype with the phenotype. So this was an MRI study where they looked at 89 patients that had DCM gene mutations, and they looked specifically for this ring-like pattern of enhancement. And they found that there was a tendency to see this more in patients that had the DSP FLNC genotypes, but it wasn't present in the other genotypes. And they said that we should probably consider this as future diagnostic criteria for ALVC. So again, take-home points, this is clearly a malignant pattern. We see this in younger patients. The degree of fibrosis precedes the LV systolic dysfunction. And it's seen only in certain genetic dilated cardiomyopathies. We probably should continue to define that a little bit better, and it is associated with an increased risk of arrhythmias. So the guidelines do mention this. The guidelines mention, look for a lamin-AC mutation if they have 2 or more risk factors, even if their EF isn't severely reduced, because they would probably benefit from ICDs. But to me, the question still is, now, none of the studies that I looked at, not the first 2 studies that I looked at didn't really look at genotype with phenotype, but phenotype is what represents substrate. And it's not just the genotype that's responsible for increased risk of arrhythmic events. So in the future, should we not be focusing a little bit more on the pattern, the scar burden? Isn't that what's really going to prognosticate better in terms of arrhythmia in these patients? So the 2022 ESC guidelines does a slightly better job than our guidelines from, I think, 2017. They talk about LGE burden in HCM. They talk about LGE in sarcoid if they have an EF greater than 35%. Once the active inflammation has resolved. They also say that if they have EF 35 to 50, even if it isn't significant LGE, if it's minor LGE, it's still a 2A recommendation to take a look. And when they talk about pathogenic mutations in genes, they include a lot of other genes. They also talk about muscular dystrophy and a 2B recommendation for patients with muscular dystrophy. So they cover a lot more, the spectrum of patients that they cover is a lot more based on these guidelines. So the question is what's happening in clinical practice, because the guidelines, the ICD guidelines from 2017, the ESC guidelines are from 2022, and a lot of the studies that I just quoted are from in between that period. So for 2020, 2018, 2021. And so this was one of our cases here that we, a cardiac sarcoid patient that was biopsy positive cardiac sarcoid, had a reduced EF. It wasn't severely reduced, and we quantified scar on this patient 13%, so much higher than that Shenoy cutoff of 5.7%, but also has some very concerning scar patterns here. So RV side of the septum. This patient also had some degree of RV free wall involvement, plus combined with scar burden, and I think the patient also needed a pacemaker. So multiple reasons to get an ICD, but we did incorporate that, and we used that as a reason to get this patient a primary prevention ICD. But I was curious what everyone else is doing, and this slide by no means is any kind of rigorous research. I just pulled 10 of my friends that are also heart failure specialists in other institutes around the country, and I asked them what they were doing. 10 heart failure specialists, 8 large academic centers in the US, and I think we covered Northeast, South, and West Coast. And I said, if you have LGE in cardiac sarcoid, if you have LGE in dilated cardiomyopathy, LGE in suspected ARVC, AVC, or lamin, or LGE even in ischemic cardiomyopathy, which I haven't talked about, but they have a mildly reduced EF and extensive scarring, do you use it to determine which patients would benefit from an ICD? And as you can see, the responses are kind of all over the place, but a lot more people are using it in patients with cardiac sarcoid. So 7 out of 10 people said, yes, if my cardiac sarcoid patient has LGE, it's going to change my decision as to whether or not they get a primary prevention ICD. I think the ARVC, AVC, Lamin category, about 2 or 3 of them didn't have a lot of experience, so they said they really can't comment. But interestingly, even in patients that had dilated cardiomyopathy, no genetic mutations, no sarcoid, no AVC, et cetera, 4 out of 10 people still said, yeah, I take it into consideration. Of course, everyone takes it into consideration with regard to heart failure. 3 out of 10 people also told me that if the EF is mildly reduced and there is an extensive amount of scar, they still tend to make an argument for, this patient would probably benefit from an ICD. I apologize, Dr. Panza, there's only one slide on this because there was way too much to cover with LGE itself. But I do think that in the future, we're probably going to rely more on late gadolinium enhancement as the next step. But beyond that, we know that we get additional information from MRIs, right? So we get assessment of T1 mapping, which gives you a sense of how much interstitial fibrosis there is, which is not going to be captured if you just use LGE. And we get a sense of ECV. And so these 2 studies, the one on the top looked at 225 patients, followed them for 2 years. And again, ECV and T1 were independent predictors of arrhythmic events, and ECV was an independent predictor for heart failure events. And in the study, the one in the bottom, which was done in Europe, so I think Spain, Ireland, and the UK, 703 patients with dilated cardiomyopathy followed for about 21 months. And again, EF, LGE, and ECV were all found to be independent predictors of significant arrhythmia. And I didn't touch upon this at all either because it would have been a very lengthy talk, but we can probably use LGE also to risk stratify patients that have ischemic cardiomyopathy, because there are a lot of papers that have looked at infarct and the peri-infarct zone, which have intermediate signal intensity, so only 2 or 3 standard deviations above what normal myocardium is. And they tend to be substrate for ventricular arrhythmias. And so if we quantify that, and there are ways to quantify that, those patients likely benefit more from a defibrillator than patients that don't have a significant burden of peri-infarct scar or peri-infarct LGE. But again, I haven't covered that. I just know that that's where research is currently, there is ongoing research in that area. So for the future, I think the only interesting randomized control trial that I did find, although I do believe we have plenty of information already, is the CMR GUIDE trial. So this is a randomized control trial where they're taking patients that have EF 36 to 50%, right? So they could have ischemic or non-ischemic cardiomyopathy, anywhere between 36 to 50%, and they're randomizing them to ICD or no ICD based on a CMR guided management strategy for ICD insertion. So presence of scar or fibrosis, and they're trying to determine whether that's going to be superior to the current standard of care strategy. And I think that they're supposed to complete that. I think it's 2025, so we'll find out then. Okay, but my conclusions, I think overall, the prevention of sudden cardiac arrest, sudden cardiac death has not really been a success story. We've seen a reduction in ischemic heart disease. We've had a lot of success in HCM patients, but overall, we can't really say it's been as successful as we wanted it to be. We know non-ischemic cardiomyopathy is a heterogeneous population, and it's difficult to risk stratify these patients. But the current tools that we have, which is LVEF, it probably gives us more information about prognosis regarding death, cardiac death, all-cause mortality, and heart failure. But LGE and SCAR probably does a better job of risk assessment for arrhythmias and sudden cardiac arrest, sudden cardiac death specifically. When it comes to LGE, we shouldn't be focusing only on scar burden, but scar pattern is clearly very important. And when it does come to scar quantification, everyone's doing some degree of visual estimation. So the specific cutoffs that papers use, 15%, 5.7%, et cetera, they're probably not as helpful as a range. Certain scar patterns where I think we're going to see a lot more research in the coming years, specifically the ring-like pattern, are concerning for genetic cardiomyopathies. And you'll find them in patients with normal EF. They may just have PVCs or non-sustained VT. And so we really would miss these patients if we didn't evaluate them further with an MRI. guidelines usually we know lag behind practice, and LG is already being used in clinical practice to guide decision making. But I think the future we should expect to see a greater role for parametric mapping as well. My last slide. Thank you.
Outstanding. I thought you were going to get me out of the T1 and T2
No,
black box, but you didn't. I mean, I think it is amazing that we still rely on ejection fraction, which is probably one of the most imprecise measurements that we have in cardiology to make a very important decision. So this is great. So one thing that always has puzzled me is why, in hypertrophic cardiomyopathy, when we have a diagnosis, we ask for an MRI to look at LGE, as part of the risk stratification. But usually when we ask for CMR for other conditions, it's basically because we suspect sarcoidosis. And when we discuss the findings, we don't discuss about sudden cardiac death stratification. Is that part of your of the report, that you always report risk of sudden death?
In HCM?
No,
Or in
in
everything
non-HCM.
So I think we don't routinely quantify scars, so we're not routinely doing, scar burden quantification on everyone. We can, so it's not, it doesn't need to be specified, it's already part of the protocol. So we can do it, but I think what we tend to do is we report on how extensive it is, whether it's HCM or any other, specifically HCM, sarcoid, or any of the ring-like pattern ones. We tend to report that it is extensive. And then at least what I think I do is I have a conversation with the attending taking care of the patient, and I ask, or we discuss whether scar burden quantification would be helpful.
But what I'm saying is that, let's say that we suspect the patient has sarcoid.
Yeah.
And you do an MRI, and
Yeah.
then when I hear you guys talk about the results,
Yeah.
you show the pattern of LGE, and then you say, well, this is likely sarcoid or not.
Yeah.
But never heard you say, okay, this is,
Higher risk.
I mean, that 5.7%, I had never heard of. So
Yeah.
I think you should provide a recommendation, because I don't think everybody's familiar with the risk of sudden death. The other question I have is, at the very end, you showed about ischemic cardiomyopathy, but ostensibly you left it out of your entire presentation. So why is that we don't use this for ischemic cardiomyopathy beyond EF?
I think we should. I just think that there is a lot of data that suggests that, specifically identifying patients that have that peri-infarct, that border zone, which is arrhythmogenic, quantifying that is more useful in determining what their risk is of arrhythmia. But I guess the reason we're not doing it routinely is because the guidelines haven't changed, so it wouldn't change management of those patients. I really think that's the lag. The fact that we're still sort of relying heavily on EF, and it wouldn't change management even if I did report that, or we did do it routinely, I think it wouldn't change management. Having said that, if I have an ischemic cardiomyopathy patient, I do tend to have a lower threshold to do an MRI on those patients.
And there are no studies like in HCM about, some people said 10%, you said 15%, or some of the guidelines said 15%, but for ischemic cardiomyopathy, there is no such even proposed threshold percent of scar.
No, I think there were proposed thresholds for that peri-border zone, but I don't think that there is a specific percentage in the way that there is for HCM for ischemic just yet.
Okay.
Great talk. So, yeah, I think your talk really highlights the struggle with infarct burden and the heterogeneity of that, whether it's ischemic cardiomyopathy with the peri-infarct zones, but even in non-ischemics with, remember, it's not, if you have a cinder block of scar, it's not arrhythmogenic, right? It's the surviving dead or diseased cells that are maybe going to die soon, but still alive and electrically excitable. Those are the areas that we worry about, whether it's ischemic cardiomyopathy, peri-infarct zone, or other tissues. So in quantifying that isn't just, how much is it, what's the surface area, thickness, what else is going on with that, and maybe lower scar brightness is worse, like you said. And I think the reason we don't think about it as much as ischemic cardiomyopathy, because in non-ischemic, that's when, when you said to us, and we tried to prognosticate a little bit, that's one of the factors we could use in a non-ischemic cardiomyopathy patient, especially HCM, but others. Whereas in ischemic, we we're interested, but at this point, like I said, we can't really use it. We don't have as much leeway to use it.
And in response to that first part of your, what you were saying, the non-ischemics, I think there are also a lot of studies that specifically look at in conjunction within SCAR or the conduction zones within SCAR and even in non-ischemic cardiomyopathy. There is ongoing research there. I think it's just less robust than the extent and the pattern of SCAR.
Stephen.
Thank you so much for talking about the ring pattern, because that is plagued my life. And I know you're not gonna be able to answer this question. Well, at least I think you are. You're amazing. What, like, how much of the ring has to be there when we consider it a ring? Like, you have this double stuff. It looks like it's a half moon. Then it's the crescent. You know, like I've seen it before. People only call it the ring when it's all the way around. But we know that that's the late stage, right? So
The way they define it is 3 contiguous segments. So either subepicardial or mid-myocardial. So if I see anteroseptum, interseptum, inferior, I'll call it.
okay. I always worry that it's stuff we see all the time.
Yeah.
It will be.
It'll eventually do that.
That's it.
Yeah, and so I don't know the answer to that. Should we repeat that MRI in a year or 2 years to see if it's progressing? Should we give them event monitors and monitor for non-sustained VT or just do or genetic testing? It's unclear.
And then the insertion point.
Yeah.
Scar, like what?
So
And-
I think most of these studies actually excluded patients with
Yeah.
at least a couple of them. I can't remember all, but a lot of them did exclude patients with that RV insertion point scar and didn't even use that in terms of stratifying patients.
Dr. Rojas has a question. Says, can the lady has been decreasing cardiac sarcoid with steroid treatment.
Yeah, so again, I don't have a great answer for you, Radamis, but I'll tell you that I think Steve and I have talked about this. One of my projects when I was doing my imaging fellowship was we followed a lot of patients that had sarcoid that underwent MRI, and a bunch of them most of them actually were on some form of steroid therapy, and we followed them for 3 to 5 or 6 years. The ones that had scar, and there were very few of them, we didn't see a significant difference in change in scar burden. So I think in PET, you do see it because that's more active inflammation. You'll see a change in T2 for that same reason. You don't really see a significant change in scar burden. after
Although
steroid
I
treatment.
saw in one of the slides you show about the guidelines that it was the percent of LG after anti-inflammatory treatment. So I took it to mean that you only measure it after treatment.
Right. So I guess in my mind, what I'm saying is if it's not active sarcoid, right, and if it isn't a lot of inflammation based on PET or MRI, then that scar is not really going to change because that's permanent and that's fibrosis. But if it is active sarcoid, there is active inflammation and you're treating them with steroids, then it should get better after the flare. I think we're not really sure how we follow that. I think a lot of places will do PET, a lot of places will do MRI to follow that, but in the permanent scar, you don't see a change.
I'm sorry, we talked about 3 types of scar on the infarct, the interstitial fibrosis, which I assume is remodeling.
Yes.
What was the third?
Replacement fibrosis, which you so typically what you see in non-ischemics, so myocarditis or sarcoid, which is that mid-myocardial fibrosis.
Along those lines, are there any longitudinal studies to see if those 3 types of fibrosis they get worse? I mean, you know what I mean? Are there any?
Like if
Or
they,
they
in
treat
terms of
the
birth,
same things, they're not a continu, they're not a.
that I specifically came across, to be honest, you're whether they,
Improve or get worse, or, you know, following, especially the interstitial fibrosis patients that we see.
Yeah.
Do they ever get better? Do they get worse in spite of improvement in the, improvement in, you know what I mean?
I didn't see specific studies that looked at, so you're basically saying you do T1 mapping on a patient that has a non-ischemic cardiomyopathy to get an assessment.
Because
and-
we all see patients that they clinically get better, their EF gets better, that they die of sudden cardiac death.
Yeah.
I'm just curious, is there anything
Yeah.
longitudinal that?
I didn't come across it. There may be, but I personally didn't to look at, remodeling over a period of time. I didn't come across any of that specifically.
Thank you.